Hey, so one of the things that I really want to talk about, especially with my students, is a brief overview of certain medications. I'm calling it kind of a hodgepodge of medicines. We've got hypertension, hypertensive or antihypertensives, anticoagulants, antiplatelets, all that good stuff that deals with bleeding and clotting and all of that, seizure medications and more, diuretics, and just here and there little bits and pieces, but that are important things that you need to know. So let's get started. Okay, so the first medicine that I want to talk about is ACE inhibitors. They're known as the Prils. Anything that you see, Captopril, those type of medications with Pril at the end, you should automatically think ACE inhibitor. It's a great way to remember them. ACE inhibitors lower blood pressure, but not the heart rate. Now, for my students, if you're in the clinical setting, for nurses out there, you should always be getting a heart rate and a blood pressure and respiratory rate and oxygen saturation. That's a given. But just so you know, ACE inhibitors and ARBs don't lower heart rate, but they lower the blood pressure. So if you had a higher blood pressure or a lower heart rate, we can give those drugs, those medications, and it's not going to affect that. They're black boxed for fetal toxicity. They're fetal toxic. So if you're a pregnant mama, that's a big no-no. If you suspect a patient to be pregnant, and I just go on record to say this, is that any female that is in an age that could have a baby, and nowadays it's pretty old, you need to ask and we need to check, right? We need to just send down a pregnancy, urine pregnancy test. If it's negative, everything's good, you can give the drugs, but be very careful in giving them. It can cause angioedema, and that can be very life-threatening if we're not careful. One thing with the ACE inhibitor is you can have this dry, hacky cough, and most patients or clients that start taking this medicine will get this. And you need to let your patient know this, that this is a possibility. They don't have lung cancer, they don't have pneumonia, there's nothing crazy going on. This is caused by the medication itself. And once the medicine is stopped, it goes away. But there are people that get out there and someone doesn't tell them that, and they start having this cough and they're concerned, and then they start treating themselves for a cold. It's taking over-the-counter cold medicines and stuff like that. So we want to be very clear in our teaching to our patient on an ACE inhibitor. They could have a dry, hacky cough. It can cause elevated potassium levels, so we need to watch and look at our potassium. And also orthostatic hypotension is a possibility. So always slow moving in our slow position movements. If you're going to stand someone up, or you're going to sit someone up, or you're going to turn someone, any of that, to stand up to walk, we want to make sure that we do it very slowly so that this patient or client doesn't have any issues, fall, or anything like that. We also want to teach them this. If they're taking this medicine at home, when you get up out of your bed, to slowly sit up, give yourself some time. I always say, pump your feet like a duck, let the blood flow a little bit, give it a good minute or so. And then once you feel okay, then to the next movement we go. Stand up, always knowing that the bed is behind them if they're getting out of bed, or the chair. And if they feel lightheaded or dizzy, just to sit back down on the bed or in their chair. Safety is a must. Never stop abruptly this medication. It can cause rebound hypertension, and that means that it would go and even higher that blood pressure, and to get that back down is even more difficult. So they need to always take the medicine, call their physician. The physician can advise appropriately. If they're in the hospital, you would call the doctor if they refuse to take it or anything like that. Captopril is an ACE inhibitor. It's one. I advise looking up others just to see, but for this one, you want to take 1 hour before meals, and this helps increase the absorption of the medication. You don't want to take it on food or take it and then all of a sudden eat really quickly. So that's something to also teach your patients or clients. So the next blood pressure medication I want to talk about are ARBs, which are angiotensin receptor blockers. They end with Sartan. We say it because Sartan, there's different ones out there. If you see Sartan at the end of anything, think ARB. That's what it is, an angiotensin receptor blocker. This lowers the blood pressure, once again, same as the ACE, but not the heart rate. It inhibits or blocks in the RAS system, that aldosterone angiotensin 1, angiotensin 2. It blocks that in the RAS, which is what will help with decreasing our blood pressure. It is black boxed for fetal toxicity, so definitely no pregnant women should be taking this medication. And just like I said on the slide prior, we always want to make sure that they're not. Don't just ask someone, hey, do you think you're pregnant? Always be like, when is your last period or menstrual cycle? And then just to just be super safe, go ahead and send a urine pregnancy test just to get that negative so you are clear, especially if they haven't been taking the medicine and you're starting something new. This also can cause an elevated potassium. It's going to hold on to potassium. We want to watch. I have the vegetables and avocados, melons, oranges, and liver to be watched, but these are things that they should not eat. Lots of green leafy vegetables, avocados, melons, oranges, and liver. This is going to help increase potassium even more. So we need to be very careful what we tell them to eat. And also, once again, slow position movement. Oh, LOL. Beta blockers, they are. Anything ending with the LOL, metoprolol, toprol. We see that LOL, right? That identifies as a beta blocker. Now, for my students, you can go on and watch other videos that I've made that go in depth on where and what and how ACEs work, ARBS work, betas work. But just so you know, this affects both. There are some that affect beta 1 only and some that affect beta 1 and beta 2 cells. One heart, so if it's a beta 1, it's going to only affect the heart. If it's a beta 2, it's going to affect the heart and the lungs. We have 2 lungs. So instead of slicing and dicing that, for my students, I want to just say, just any beta blocker, you want to question this. Go look it up, make sure it's not the one that affects. So any beta blocker ending with an LOL that you come across, if you're not sure if it's a beta 1 or beta 2, look it up, make sure before you give it. So in broad stroking this drug, it decreases the workload of the heart, which will decrease the blood pressure. If we bring the workload down of the pump of the heart, we're going to decrease our BP. It also decreases the heart rate. So if I have a high BP but a low heart rate below 60, I'm not going to want to give a beta blocker because I'm going to lower that heart rate even more. And with that, it's going to bring on orthostatic hypotension. So we can get patients into a lot of trouble if they're too low with BP or heart rate by giving this med. But also, too, just so you know, we're lowering everything, and it's going to really cause orthostatic hypotension. Once again, I have that it affects beta 1, beta 2 receptors. So because of that, the ones that affect both receptors, heart and lungs, we never want to give to an asthma patient because it can cause bronchospasms. This is an emergency situation. If a patient has a bronchospasm, it will stop breathing. And so we need to make sure that we're very clear in who we're giving, looking at our history, looking at, any other medical history for giving these medicines. Don't just assume that because the doctor ordered it, it's okay to give it. You are the one giving, you will be held responsible. So I'm saying to you, look it up. It can, just so you know about beta blockers, they can mask hypoglycemia in diabetic patients. We want to make sure we educate our patients that have diabetes on this, and also too, if they're in the hospitals or clinics with us, that we're aware of that. Fatigue, and that can cause fatigue, which I think just about everything can in our world anymore, but it can, and erectile dysfunction. And so this is so very important to also teach our patients or clients because they need to understand that. If it's a 34-year-old male patient that's getting this medication, they need to be aware that this might be a situation that happens by taking this medication. It's black boxed because if stopped abruptly, it can cause angina and or a heart attack or a myocardial infarction. So never stop anything abruptly. And that's just a rule of thumb. And, always, I just tell every drug, never stop it abruptly. Always call your physician. Always, ask before stopping anything because you don't want the side effect. And for this medication, if you stop it abruptly, it can cause you to have a heart attack, chest pain and a heart attack, increase in oxygen need of the heart. And so we don't want that. Nope. So our next medication antihypertensive that we want to talk about is calcium channel blockers. They do exactly what they say. They block calcium. Now, they block calcium in the blood vessels and in the heart, just so you know. So when that happens, vasodilation takes place, excuse me, and the vessels will vasodilate out, and it decreases the workload because of this. But this is what can happen. By doing that, we can have peripheral edema, and that's important to understand and know. We need to teach our patient and understand that if we're giving this medication, it might be a side effect. Bradycardia, it is going to affect the heart, not only the blood pressure, but the heart rate. Constipation, and this is something that it needs to be shared. If I have a patient that's going to have constipation from a medication they're taking for their blood pressure or the heart, they need to know that, and it either increase fiber, increase fluid if possible, but a lot of patients with cardiac disease can't increase a ton of fluid. So we definitely want the fiber. We definitely want a stool softener, and if needed, a laxative, but that's the very last resort. Stool softeners are our friends, so we'll have them take that daily or drink fiber if they need to, or increase fiber in their diet. It can cause headaches, and this is a biggie for calcium channel blockers. No grapefruit juice. It can interact and increase the medicine in the bloodstream. So it's an absorption issue. Some create different absorption issues with what you're taking, but for calcium channel blockers, if you're drinking grapefruit juice, it's going to increase absorption of this medication, and you're getting even more of the medicine than what you need, which can then what? Cause a lower heart rate, a lower BP, a lot of issues. So we don't want that. So no grapefruit juice, calcium channel blockers. So let's talk about Lasix or furosemide. It is a diuretic that you are going to give. I don't care where you're working. You're going to see it in a history. You're going to give it as a nurse. So it's something you need to know. It is a loop diuretic, meaning that it takes place where its mechanism of the action is in the loop of Henle in that kidney. And for my students right now, I'm wanting you just to understand what's going on and what it's doing. So don't worry about that. But if you want more information or you want to understand more how it's working in the body, I do have a video, other videos on my channel that break down these medications a little further and in depth. But for right now, it's a loop diuretic. It's a potassium waster, meaning we're going to pull potassium and urinate it out. So if that's the case, then we need to watch our potassium levels and replace potassium. It is a medication. If a patient's getting it, we want to look at their potassium levels, knowing and understanding it's a potassium waster. We want to make sure that the physician gives them a potassium supplement. Now, not all people need the supplement, but the majority do, because you need to get it through foods, or if they have a disease process that makes them hold on to potassium, like chronic renal failure, they don't need that potassium supplement. They have too much potassium, and hopefully it'll help pull some of it and bring them down, just depending. It increases the excretion of potassium, calcium, and magnesium. So we're going to look at all the electrolytes on the panel to make sure everything is within norm. At risk for dehydration and fluid electrolyte imbalances, because we're pulling mass amounts of fluid and urinating it out, so we can dehydrate our patients. So we need to make sure that we watch for that. It's an ototoxic drug, so we want to be very careful. It can cause ringing of the ears and even deafness if we're not careful. It can cause hyperglycemia. We want to always give this medicine before 5 o'clock. So really it needs to be given in the morning so the patient can get up and go to the restroom all day long, urinate, in hopes to sleep at night. It's a safety issue. If patients take it at night, they'll be up every hour to 2 hours going to the bathroom throughout the entire night. So we don't want that. Or they're at risk of wetting their beds. They're at risk of falling due to, being a little bit out of it, getting up, waking up, or tripping over something. Lighting is an issue, all of that. So we want to be safe. 20 milligrams per minute IV given slowly. You want to always give this medication slowly because pushing it will cause ototoxic effects. So we want to go very slow with it. question yourself, even slower, but at least 20 milligrams per minute. Weigh the patient daily. We are pulling mass fluid. This is going to speak volumes to you about dehydration. It's also going to let you know where your patient stands. Monitor INOs. We want to know what they're drinking and what they're putting out if they're in the hospital or clinic setting and you're watching them or you're nursing them. Monitor your electrolyte levels always. So you need to be drawing labs and watching. Now, if patients take Lasix PO, they've taken it, they go home, the physician, they get to a sweet spot. And what happens is they can be home taking those meds without any difficulty. And they'll go in maybe once a month and have lab work pulled. But if they're in the hospital and we're giving this for whatever reason, then we need to be doing these things daily. And that includes observing or watching that their electrolytes, so that we know they're not in any electrolyte imbalances. And that would be suggested to the doctor. The doctor must order the labs. But as a nurse, you need to think that way. So the next diuretic is hydrochlorothiazide. It's a thiazide. There's a whole group under thiazides. This is one specific. It's not the only thiazide diuretic out there. But the thiazides end with ides, just so you know. They can cause dehydration. Of course, they're going to pull fluid. They actually take place in the distal tubules, a little bit different area of the kidney. So just so you know, they are potassium wasters. They can cause, of course, low sodium and low potassium. That's your hyponatremia and hypokalemia. We want to administer also these during the day so that the patient's up and urinating throughout the day and not at night. Weigh daily. INO again, once again, monitor electrolytes. But the big thing with hydrochlorothiazide or thiazides is they cause photosensitivity. So make sure that the patient's wearing sunglasses and sunscreen. Any patient that there's photosensitivity involved, we need to teach them that they're at risk to sunburn or be more at risk for damage from the sun. So they need to understand that. So just a really quickie is potassium sparing diuretics. So as much as we have potassium wasters, meaning we're pulling potassium and they're urinating it out and we're having to replace it, we do have potassium sparing diuretics. Aldactone or spironolactone is a one. There's several others out there. The thing that you want to know about the potassium sparers is you want to avoid salt substitutes because they're highly enriched with potassium. So patients that are trying to watch their salt diet for high blood pressure, if they're taking a potassium sparer and we're not pulling potassium off with the medications, or if there's a reason, we just need to be very careful. Any patient using salt substitute needs to understand there's potassium in this and that it can affect them. Hyperkalemia is one of the side effects that we have to watch for. And so we will also monitor potassium levels because once again, guys, if it's a low potassium or a high potassium, we need to worry about cardiac. One way or the other, it's going to affect the heart. Now, yes, there's other answers out there to potassium, but when you see potassium and think potassium and abnormalities of potassium, you need to think cardiac issues because that's what really affects the heart. The others do too, but this is the one we see, just FYI. Now, this is a diuretic, mannitol. It's an osmotic diuretic. And the deal with osmotic diuretics, just so you know, is they're going to pull volume out and pull volume out and into the circulating volume of the body. So that's why if we're giving mannitol, it's going to pull it out at a cellular level. So we're going to decrease the intracranial pressure. That's what we give it for. It's to decrease that intracranial pressure if we have any reason for that. If we have an increase in intracranial pressure, we give a mannitol to help decrease it. But by doing this, it's a systemic situation, so it's going to affect the entire body. So what happens is as we pull that volume, we get too much all circulating in there, we're going to end up with pulmonary edema if we're not careful. We have to be careful for heart failure patients, renal failure patients. It can cause dehydration. Sodium and potassium imbalances. And we always want to monitor weights, I's and O's, and decrease ICP.